Welcome back to It's Your Case, presented by VetCT.com. I'm Heather Chalmers, your radiologist on demand for this week. Today we have a 3-year-old small crossbreed dog with a history of ataxia on all 4 limbs and weakness. Over the past year, you'll recall we have covered radiographic findings in small animals for thorax, abdomen, and musculoskeletal systems, along with some special sections on neuroimaging, equine imaging, and most recently, I hope you enjoyed our exotics imaging takeover. Today, I'd like to show you a CT scan. CT scans are acquired in one plane, usually transverse. In this case, we did a CT of the dog's neck. I will start by showing you that we're at the cranial edge of the CT scan, which starts at the dog's ears. These are the tympanic bulla, filled with gas, and you can see the external ear canals extending bilaterally. I will now scroll caudally as we go past the caudal edge of the head and we start to see the cranial cervical vertebral column. Here we have the back of the skull and the craniocervical junction. Scrolling through the cranial cervical junction in transverse allows us to assess C1, the first vertebrae, and C2, the second cervical vertebrae. We can continue past C2 and look at C3 as well. One of the advantages of CT, although it's acquired in one plane, is that we can reconstruct it and assess the images in multiple planes. Because in a small breed dog, I'm often interested in looking at the alignment of the craniocervical junction, it can be really helpful to assess that in sagittal and dorsal planes. I will now convert this into a sagittal image for us to look at. And I'm going to flip it so that the head is facing to the left. So here, the CT reformatted into sagittal, and to orient you, here we have the back of the skull, the first cervical vertebrae, and the second cervical vertebrae. This would be C3 and C4 continuing caudally. An endotracheal tube is in the trachea, which is showing up down here. Now you'll recall for the musculoskeletal system, including the spine, that I like to use the ABCDs approach. A is the first one, and that's alignment. A sagittal image is a great place to look at alignment in this case. When I look at the position of the dorsal arch or the spine of C2 relative to the dorsal arch of C1, I see more space here than I would expect. Normally, the space between one vertebral arch and the next would be more similar to what we see here at C2-3. So this is a sign of increased space, which is concerning for malpositioning or subluxation. As you know, I always like to confirm my suspicions with other things. So if the dorsal part of C2 is in the wrong spot, we'd better also check the ventral part of C2. The cranial aspect of the vertebral body of C2 is modified to form the dens. The dens is a cranially projecting process that is supposed to sit in the floor or ventral aspect of C1. So in fact, if this were the dens here, it should actually be touching down at this level here. So not only is there increased space between the dorsal part of C2 and the dorsal part of C1, but we're also seeing displacement of the dens. Another thing I'd like to assess in this case is what's going on with the shape and the size of the dens. In order to get an idea about that, let's look at it on a dorsal plane. I'm now going to rotate it so that cranial is at the top. So here we have C1, and we're looking at that tip of the dens of C2. The dens normally would be substantially larger than this. In addition, in order to keep the dens at the bottom of the first cervical vertebrae, there are soft tissues that support it. There's a series of 3 ligaments that would be in place. These can be difficult to see on CT, but when the dens is hypoplastic, often the ligaments are either hypoplastic, absent, stretched, or insufficient. Looking at other aspects of this case, I'm going to go back into the sagittal view so that we can take a quick peek at the alignment of the caudal head and C1, which to me looks appropriate. You may notice that there's a very slight mineral feature here between C1 and the caudal aspect of the skull. Sometimes we see a little bit of meningeal mineralization there as an incidental finding. I do not think that this is related to the dens, although it is possible that there could be some dystrophic mineralization related to the ligament insufficiency. So for this case, I would conclude atlantoaxial subluxation with associated hypoplastic dens, as we've seen. The neurological signs related to all four limbs having weakness and ataxia are consistent with some spinal cord compression at this level. Although this is difficult to assess with CT, we can conclude because of the level of malpositioning coupled with the neurological signs that there is some spinal cord compression. These lesions can be dynamic, and careful patient handling is warranted. Be sure to review the full report associated with this case. Thanks for listening, and remember, it's your case, so please post your questions on social media.